Evening, everyone. Welcome to week 5 of the Corona CPD. Just waiting for a couple of people to come in. I've seen some new names on the list. That's really cool that you've joined us. Thanks for joining us there. I'll just give you a bit of a lowdown about what we do if you've not done this before. So we look at a case study, and we split the case up over 3 sessions. So we do a Monday session, a Wednesday, and a Friday session, all at 6 o'clock. And I kind of give you, tonight we'll give you the case, a little bit of a synopsis about what's going on with this particular individual. And then on Wednesday, we'll give you a little bit more information. And then Friday, we'll do like a sum up. So if we've got hey, Namir, good to see you again, mate. And we've got a Facebook group. Hi, Natalie. So, and Mark as well. Hi, Mark. Evening. So we've got a Facebook group. If you type in @MTECPD into the search bar of Facebook, then it will come up with our group. And if you've got any questions or you've got any thoughts on the case, then you can put them into the group and share your thinking. But we've got a session today, usually around about 20-25 minutes for the first one. Something with it kicked me out, and he said, "Okay, Peter, no problem. Good to have you back." So we've got hip and pelvis today, so we're going all around the body. So that's the plan. If you've not met me before, seen me before, my name is Mike. I'm the Education Director of Movement Therapy Education. We run training courses ourselves as a company, and I also teach for Rock Tape, teach for NACI as well, NACI Europe, and I think that's it at the moment. So it's just those 3 keeping me busy enough at the moment. And I'm a clinic director of Movement Therapy Clinics. So I run a clinic in Birmingham. There's a team of 10 of us. And we all do different things. So we've got dietitians and physios, osteo, strength and conditioning, personal trainers, sports massage. So we all work together and referring patients between each other. And all of the stuff that we talk about on this is what we do in the clinic. So that is me. This is our plan over the week. So if you've done the sessions before, apologies going over this again, but just for those of you that haven't done it before, we do case history, go over SOAP notes. So subjective, objective, and then assessments and planning, red flags and pathology. So we look at red flags and pathology. That's our key thing, really, looking at clinical reasoning and red flags. Working out an assessment plan, what kind of tests you can do in assessing and risk stratification for the individual from the case, and then putting together a plan about what we should do. Invariably with these, there's something wrong with them, and usually they need referring, but it's trying to work out what could be the problem. Okay, so useful to go through this process to try and figure out what might be going on. Cool. So I had a question at the back end of last session on last Friday. I think it was from Maria, if I remember correctly. So she was asking about what you do if you do have someone that you need to tell to go to A&E. Kind of what's the process? And it really depends on the person, depends on the individual. I think if it was a brand new patient and I didn't really know them that well, then it's a little bit harder to judge. Obviously, you don't want to scare the bejesus out of someone, but also you equally, if you do think there's something wrong, then they need to get to hospital. So when it's happened to me in the past and I've had to send people away, what I've said is, look, I've done all these tests. There's a number of things it could be, and I use the words likelihood. So I say when we look at the test that we've done, it's less likely that it's a musculoskeletal problem, and it's more likely it's something else. We can't tell exactly what that is, but we think that we need to go and get you checked out. And I've had to send people back to the GP. I have had to call ambulances for people. So I thought one person had fractured their neck. So we got them an ambulance to take them off to A&E. I don't think I've had any others that have had to go to A&E. Most of them have been GP. So then when it's a GP referral, I write them a letter. And we talked about this a couple of sessions ago, I think. What you've got to do on those letters is go through all of the testing that you've done. So you're not giving your opinion, but you're giving your objective data. So you say, right, I've done this test and this was the finding, this test and this was the finding. And then based on those, we'd like further opinion. Okay, so we'd like your thoughts on further investigation. Those are usually the kind of that's usually the language that I would use. So hopefully that's helpful for you. Okay, so again, apologies if you've done this is the fifth one that you've done, but we're going to go through this process again. So first appointment, sifting through all of the information to see what comes out. So there's no recipes with this. There's no right answers, no wrong answers. Only thoughts and justifications. So you, as long as you can justify what you said, then yeah, that's fine. Just had a message from Nicola, sent one to A&E. He had a crushed vertebrae. Yeah. So something like that is, if you think that's what's happened, then you say, look, I'm really sorry, but I can't treat you today, and I think we need to get you an ambulance right now. So I know a couple of my colleagues have had patients who've had cauda equina, and they've had to phone for an ambulance for them as well. So yeah, there's some times when I don't know, because it doesn't happen very often. I think it makes you a bit concerned. But if you're at all worried, I would send them, because the thing is, I've had this before when I was a teacher as well. So I used to be a teacher at a college, and we had a girl who had an overdose, suspected overdose. And so I went up and did my first aid with her, and I said, right, okay, we need to call you an ambulance. So I called an ambulance, and then she got up and ran away. So I tried to chase her down, but she just gone. No idea where she'd gone. So in that scenario, there was nothing more I could do. I called the ambulance. I did what I could, but she didn't want it. So she obviously went away, and then I had to deal with the ramifications afterwards. But that could happen with patients as well. So you say, look, I'm going to call you an ambulance, and then they just walk out. You can't physically restrain them, but yeah, it's up to them really at the end of the day if they want to walk out of your building. But as long as you've done everything that you could, then and you document everything, then that's all you can do. Okay, so that's yeah. Hopefully it won't be very few and far between those kind of scenarios. So the plan for today is to introduce the case. Then Wednesday, we're going to have a look at objective assessment planning. And then third session, what do we do as usual, as we've done all week. And as I said before, please pop your thoughts down on the Facebook page, or drop me a message. If you don't want to publish it on the page, then that's no problem at all. So we're going to have a look at the hip and pelvis this time. And we've got another lady to introduce to you. So hopefully you'll be able to pick up more and more of the clues now as we're going through, because can you believe it is the fifth week that we've been doing this. So yeah, 5 weeks of practice. I think you'll be able to pick out some of those clues in the text now. So I just wanted to run over some anatomy of the region before we get going. So let's just have a look at this for you guys. Just move that out of the way. Okay, so we've got the hip and the pelvis region, which is where the issues for this particular session are. So if we just zoom into that. So if I just add some layers on, so we've got connective tissue layers, all the kind of ligamentous structures around this region. So hip capsules, So Facebook group is at MTE CPD. I'll just pop it in the chat for you, Mark. CPD. So if you pop that in the Facebook search bar, then it should come up with us. Right, just find that again. There we go. Okay, yeah. So if we have a look around this region, so you got all the ligaments around the pelvis. We've got the hip capsule around here, so all the ligaments that make up the hip capsule. Just add a few more things on there. Just move this to the side a second. Track pads are very temperamental. Okay, so and then we've got this thing here. So this is your inguinal ligament or inguinal ligament, however you want to say it. And so we've got a bit of a space there that you can see from the rim of the pelvis underneath that inguinal ligament, where some structures will pass through. So if we just put on some arteries, so that's one of the structures that will pass underneath that ligament. Okay, and we've got what we call a bifurcation, so a split in the artery around the level of L3. So that's where the descending aorta turns into the two iliac arteries. Okay, so that's around that region there. Just add some venous. There we go. And then we've got the vein around that area as well. Okay. So when it enters the hip region, that's then called the femoral artery and the femoral vein. And then if we add some nerves onto, we've got this nerve here, if I can just highlight it there. So that's your femoral or femoral nerve. Okay. And that runs underneath that inguinal ligament as well. So see, we've got all those structures there, all running underneath that area. Right, let's just take some of those layers off and we'll add some muscles on. So muscles, have got iliacus, and then you've got your adductor muscles, your rotator muscles, so your obturator muscles, and then we've got some more adductor muscles here. We've got your psoas around there. Just go onto the side as well. So all of these may be involved. Then you've got where the abdominal wall inserts down into that inguinal ligament as well. So that can be a source of herniation, especially for males, that one. But just because we've got a spermatic cord that goes through that region, so there's a hole in the floor of that area. So if it was a male, more likely to be an inguinal hernia. And then more muscle layers. So we've got the muscles now of the thigh coming up into the hip but not crossing the hip. And then we've got some that there you go, there's one that crosses, so it goes from the pelvis to the hip. So you got your glute minimus, glute medius and glute max over the top. You've got piriformis around the back. Okay, so hopefully you all know those ones. And then your sartorius muscle, TFL muscle, and your rec fem as well. Okay, so we've got quite a few muscles in and around that region too. Just going to strip all those back a second. And the bit that we don't really focus on in sports massage so much, but the viscera. So try and move this. Come on. There we go. Okay, so around this region here, so you've got all your intestines, small intestine, large intestine. This is one of my favorite bits of anatomy. If you ever get to go to the anatomy labs, ask about the greater omentum, or just Google it. It's fascinating what it does. It attaches to the bottom of the stomach there. Then we've got the liver and the gallbladder as well around this region. And you think, well, what the hell has that got to do with the hip and the groin? But you can get referrals from these regions down into the hip and the groin area. And I don't think you can see it. I don't think it's on this one. It might be on the endocrine system. Yeah, there we go. Oh, it's not too much on there. Let's have a look. There we go. And then you got your kidneys as well. Okay, so around the back there. So all of those structures could be implicated in our case. Okay, so we'll have a look at that now. Just get back onto that. There we go. Okay, so So what you have to do, again, if you've not done this before, is all of those things we've just looked at in the anatomy. So you get your anatomy books, and it's what we do in the clinic. When someone phones in for an appointment, we send them out a form that checks all of this. So it will ask them to list their case history, so that when they come in, I can already have a read of what they've written, and I can see if I need to read up on anything that's a bit strange. Okay. So it was called. This is really geeky. This one, Natalie. It's called the greater Omentum. Okay. When you read about what it does, it's fascinating for anatomy weirdos like me. Was this what we were teaching one of the lads about last year? Possibly. Yeah. So on some cadaveric specimens, it's not there anymore, but quite often you'll be able to. It depends on how old the specimen is. Sometimes it comes off. That sounds horrible, but if they've been in there for a while, have been in the labs for a while, sometimes the specimens have been there for nearly 10 years. So things like that come off. But if you've got quite a new one, then you'll be able to see it. Okay, so nice. I hope you're not having your dinner. With what you try and then do is have a think about all of the things that can impact that region. So we've got the information beforehand from the individual who's filled in their form. If there's anything weird on there, like any weird drugs that they're taking, any strange conditions that I've never heard of before, then I'll make sure that I read up about those before they come in. Okay, so we've got a pre-consultation form before they come in, and then we go through that form with them when they do arrive. Obviously face-to-face usually, but online at the moment. And what I'm doing when I do that is I'm going through this sieve in my mind. Okay, so go through all the muscles that it could be, all the bones and ligaments, and viscera is the organs that we've just looked at. Is it a fascial issue, connective tissue problem, and so on. Okay, so when you're going through the case now, these are the kind of things that you need to have in your mind to see whether those things could be causing the problem. And then we've got psychosocial issues as well, because there is a difference between having pain and being injured. Okay, so somebody can have no injury whatsoever and still be experiencing symptoms, but it doesn't mean that anything's wrong. All right. So, and that's all the pain science stuff over the last sort of 10, 15 years have taught us that you can have a horrendous injury and no pain, and you can have no injury and lots of pain. So the level of pain has no correlation to the level of damage. Okay. So initially things may be sore if you first injure something, but not necessarily all the time. There's a great video of a basketball player who had an open fracture of his tib fib, and he didn't have any pain at all. Okay, there was no pain whatsoever. So there's no definite that it hurts like hell, so that means that there's lots and lots of problems. Okay, so there may be a psychosocial issue behind their symptoms. Okay, so this is your case for this week. So we've got Mrs. R. Okay, very cryptic. So Mrs. R is a 65-year-old woman who has worked as a teacher for 35 years in primary schools. She's recently retired from her occupation and has taken the opportunity to take a long holiday in Australia to visit her sister who lives there. She's 5'3" and weighs 13 stone. Okay, so all the usual things, checking BMI, thinking about her age, what kind of conditions might be more prevalent in her age range. So those epidemiological studies. She will admit that she is a heavy smoker. She has a reasonable nutritional history, but admits that she tends to overeat and favoring fatty foods. Okay, she is married, has 2 grown-up children. She's a pleasant lady who tends to laugh and joke rather a lot as you take her history. Sounds great. She reports to you that she feels very tired and has done for the last year. Okay, so something that's been going on for a little while. That one then. Presenting complaints. So she's got a constant deep ache in the left groin inguinal area, or inguinal area, or however you want to say it. and lower lumbar spine located to the left. Okay, so if you think about the anatomy stuff we've just done, what kind of things are in that area or what could refer to that area to causing those symptoms. The pain also spreads into the left gluteal area, and Mrs. R describes the left thigh, upper leg, as feeling dead all over and painful. Okay, so those are her current complaints. So the onset, the buttock and groin have been present for the last 2 weeks. The dead and painful feeling down the leg has been a feature for the last 2 days. So we've got something that's been there for a while, overlaid by something new. Okay, so are they related or are they separate? The lumbar spine pain has been a feature for 10 years. The onset was insidious, so there's no known reason for it. And Mrs. R puts it down to her occupation. Okay, the recent groin pain seems to have been fairly rapid onset, coming on immediately after her holiday. Okay, remember her holiday was to Australia to see her sister. She seems to think that this was associated with a long journey and reports feeling uncomfortable in the buttock when she was sitting. Okay. So daily pattern, the spine pain has always been at its worst in the early morning. It is easier when walking around slowly and feels pain-free by lunchtime. Okay, so a few clues as to what structures could be involved there. The leg symptoms get worse if she needs to exert herself. She is waking up in the night with the pain. Aggravating factors. She tells you that it feels very difficult to get comfortable on the sofa or chair over the last few days. Okay, so again, that's sitting. Relieving factors. Ibuprofen taken regularly helps with all the pains, but the symptoms are still present. Okay. The recent problem with the groin and leg buttock is worsening, especially the leg pain. And examinations, she's had a difficult experience with the GP once and is therefore reluctant to see her current GP. You hear that quite a lot, even with patients that I've seen as well. Family history, mother is alive. She's in a nursing home. Father died of cancer when he was 60. Mrs. R thinks it was a problem with his stomach. She remembers he was an unusual yellow color when he was ill. Okay, so I'll give you clues to how he died. Diet, drinks 6 cups of coffee with cream most days. And she's suffering from breathlessness on exertion. She tells you that she has suffered with varicose veins for many years as well. She also reports that she frequently loses control of her bladder when she laughs or coughs. Okay. Last bit, I think. So Mrs. R suffers from intermittent pain in the right upper quadrant of her abdomen. So if you're not sure where that is, then Google that. This has been a feature for 6 months. It is possible that it's becoming more frequent. She's on no long-term drugs, but currently taking ibuprofen, 500 milligrams, one a day. And she has taken this since she came back from a holiday. Okay, cool. So there's your case. Okay, what I'll do, I'll pop the video up when it's downloaded from Webinar Jam. I'll pop it on our group so you can watch it again. Hopefully you got some notes from that anyway. So if you want to go over the case history again, once the video is online, pick out the key pieces of information that help you complete the sieve. Okay, let me just share that with you. So if you've not received that before, the sieve is now being shared with you, so you can download that. We'll look at those on the next session. We'll look at what you've put down as well for your thoughts and what's going on. I showed you an example last week of how I filled in my sieve. Okay, so you can do a similar thing. Please interact with us on Facebook. More than welcome to. It's a kind of open forum. There's no wrong answers. But like I said, if you don't want to post them, then send them to me and then I'll post them on your behalf. Okay. If you are stuck for things to do on a Monday night, I've got another chat tonight at 8 o'clock with Dan Lawrence from Rocktape. He and I are going to be chatting about clinical testing. We're going to have a look at sensitivity, specificity, validity and reliability. So if you've never heard of those before, not really sure what they are, or just want a bit of a refresher, then we'll be on at 8 o'clock and the link is on our website, on our Facebook page. Okay, so hopefully see you at 8. If not, then I'll see you on Wednesday at 6. Thanks everyone.